So we are going to go for an hour and then break. It is too beautiful day to be in here. So, but 1 hour, and we're going to see how far we get. And then I'll kind of talk to the slides because you guys will have them. What I'd like to do is take you through, deconstruct, wherever you are with your skills in ECG interpretation, I'd like to deconstruct them and then reconstruct them using common cases. And maybe what I like to do is plant seeds around things that you can remember, like intuitively, rather than things you have to memorize. And so that's kind of the approach I take with this. So we'll go for an hour and we'll see how far we get. Okay, so my first question, if my pointer will work here. Lost control of my computer. Let's see. Okay. All right. So my question to you, how do you feel about reviewing cases this morning? Or now it's this afternoon. So you're going to give me a one word or more to describe. I'm good. I think, yep. I need at least one participant. Okay. I thought, there we go. And whoever says more words, they get bigger. You know, I thought this was the coolest thing. I told my wife I was doing this. She looked at me and goes, we do that all the time in the classroom. I'm like, yeah, there you go. All right. Fine. I thought it was cool. Okay. So we're gonna do a little introduction, then we'll go through cases. I doubt we're gonna have time for the scenarios, but I am gonna give you the bonus case at the end because it will contextualize, no matter where you are, it will contextualize the utility and lack thereof of ECG testing. Okay. All right. So work calls on me to interpret EKGs in my care of patients, and I'm gonna presume that everyone in this room, that is the case. Okay. So the interpretation algorithm that I use and teach goes something like this. It starts out with who's the patient, why is the test ordered, and is this a good test? And then it's a jingle, rate, rhythm, axis, and what I call the 4 I's. Okay? This is these two things, you need to do this before you interpret anything. Who's the patient, why is the test ordered, is this a good test? Whether it's a chest x-ray or an arterial blood gas or a set of electrolytes, match it to the patient, make sure you know why it was ordered, and then interpret it, right? And make sure it's a good test. So we have to, with EKG, there are a few quick things we can do to make sure the leads are connected correctly and we have a good test. And then we've got to have some way of getting our interpretation. And I'm going to suggest to you that this little jingle, rate, rhythm, axis, and the 4 I's, the I's being intervals, the I of, I'm bastardizing the term enlargement, but enlargement sounds like an I, okay? The triad of ischemia, injury, infarction, and then ultimately interpretation. If you use this algorithm, there's virtually no diagnosis that will elude you. Because if you systematically went through every one of these steps, you will find there isn't, you name me a diagnosis that won't come out of this. It just doesn't exist, okay? So it's a really nice algorithm. And what I'm gonna do with this talk is we're going to kind of walk through some of these things, and I'm going to highlight, specifically what intervals we look at. How do we measure enlargement? What are the classic findings of ischemia and injury? What are some classic infarction scenarios? Okay. Keep in mind, at its very primordial level, the EKG is you got to go back to physics. The heart is an amazing organ of electrically active tissue. And it all works beautifully when it works in a coordinated fashion. The EKG, this running line of wiggly waves over 10 seconds, is nothing more than a summation of electrical activity in the heart. And we have to remember that vector mechanics tell us, and red stands for the electrical energy here, if energy is running in the direction of a lead, and I'm going to tell you the leads, the 12 leads are like windows. They're like all windows around this. If the heart is this thing in the room, the windows are all looking at it from different perspectives. It's the same event. You drop a straight line down the EKG. It's the same event in that 1, 2, 3 lead or RLF or 1, 2, 3, 1, 2, 3. It's the same event. It's just a different perspective. So if electrical activity is coming directly at a window, it's a major league positive deflection. If the electrical energy is coming oblique, if the only component of it is what's headed in that direction, it's a minor league deflection. Interestingly, if the deflection is perpendicular to a given window, you don't see any, it's as if there's no activity. It's the same as zero flow, right? And then the converse is true also. So if energy is away, it's a major negative deflection. If it's oblique in a way, it's a minor league negative deflection. And the reason I say this is because it makes sense when you start to look at the leads and the way they're positioned around the heart. You know, we're going to look at body planes. Turns out the EKGs are in, are we?
I can forward a little bit.
Okay.
You're good.
Okay. The body planes that the leads are attached to have to do with the best perspectives on the electrical activity of the heart. We have 6 leads that we call the axial or the limb leads. We have 6 leads that are called the diaphragmatic leads. These 6 leads and the axial or limb leads are, if you look at them and you do semaphore here, 1 and 2, 3 and F, and R, AVL and AVR. And if you do that again, AVL 1, 2, AVF 3, 5 of those leads are all here, are all windows in this view. Why are they here? Because the heart is right there. The left ventricle of the heart, that is where it's at with an EKG. What is the left ventricle doing? And if I want to see the left ventricle, I'm going to position my perspective over the left ventricle. The same thing is true with regard to, okay, so here's the depiction in cross-section. Notice 5 of the 6 leads are all looking, give me information about this powerhouse, the left ventricle. The only lead that isn't is oblique to all of them, and this lead is used to just make sure everything is connected correctly. If ever there is force coming in this direction, you got something bizarre with your EKG, right? Because there's no reason for a vector ever to be coming this way, because all the energy is going this way. With regard to the diaphragmatic leads or the precordial leads upon the heart, precordium, V1, 2, 3, V4, V5, V6, why are they where they are? Because if you did a cross section through the heart, and again, you look at the boot of the left ventricle and the interventricular septum, the leads and windows are placed around the right and left ventricle. All of them. V1 and V2 in the 4th interspace, V5 and V6 in the 5th interspace, and V3 and V4 on the diagonal in between. So it's not a perfect view of the floor. It's kind of a floor that goes like this. Why like that? Because that's the way the left ventricle goes. You want windows to look at where you're going to have cardiac activity. Okay. And what's going to happen if you think about if electrical force is equal to the amount of myocardial tissue, the larger the tissue, the larger the force, the larger the vector. And we're going to see how that translates on an EKG in a second. You cross-section the heart and you use colors to depict the different points of depolarization, and you get this amazing understanding of what's going on. If everything's electrically automatic, right? If the atria were left to depolarize on their own, they would do so at a rate somewhere between, 60 and 100. If the ventricle was left to depolarize on its own, it would spontaneously depolarize at a rate of like 40. Okay. So the fastest thing drives the whole system. Now, the only place where there's conduction tissue, like wiring, like in this room, like if I hit that switch there, all the lights go on simultaneously. The only place that occurs is in the AV node down to the ventricles. And that's why the QRS is so freaking narrow. The depolarization of the both ventricles occurs in less than 1/10 of a second. Why? Because there's wiring that goes and disseminates the energy and spontaneously makes it synchronously depolarized to create a very narrow QRS. The P wave is wide. Why? Because it's cell-to-cell transfer that takes before it finally gets to the AV node, which is silent. And so the P wave, then the QRS, and then the T wave represents the resetting of the ventricular depolarization. If we're going to look at this simple schematic, we're going to remember both right and left atria depolarize with the P wave. we're going to remember both right and left ventricles depolarize with the QRS, but the right ventricle is minimal in terms of its electric activity relative to the left ventricle. In fact, the whole QRS is really more representative of the left ventricle than anything else. The T wave out here represents the resetting of the ventricle so it could depolarize again. Okay? And that's really important because we know that everything needs to reset before it goes off again. Because if it doesn't, and tomorrow you'll learn about QT prolongation and all the drugs that cause it, because if the QT prolongs enough, you get a phenomena of R on T, and all of a sudden you're depolarizing while you're repolarizing, and you got a problem on your hands. So QT prolongation is something that's very real and something we all monitor EKGs for, and we're going to have a few cases on that. But let me just summarize that what we're looking at with a QRS is this, which is atrial depolarization, slow, silent depolarization through the common bundle, and then a rapid dissemination of depolarization. The left ventricle has more wiring to the meat of it than the right ventricle. That's why the left ventricle, the left bundle is considered a bifascicular element. It has two fascicles, two bundles, because there's more to be wired than the right bundle, which is just a unifascicular. And you might say, well, what does all that mean? Well, remember, as the heart diseases, so too can the conduction tissue. And this is what creates our bundle branch blocks, our interventricular conduction defects, and really what ultimately, when we start to think about second-degree heart block, when we start to think about drugs that can slow conduction through the AV node, separation of the atria and the ventricle, and that becomes a serious problem. If atrial fibrillation is a problem, just imagine if you separate the atria depolarizing at their own 60 rate and the ventricle depolarizing at its own 40 rate, independent of each other. That's AV dissociation or third-degree heart block. And that's why people get pacemakers. That's why we're trying to prevent heart block, because heart block, if we were, one of us probably young enough, we'd be symptomatic, but we wouldn't keel over and die. You get an older person with heart block and there's no perfusion, and they can go to either cardiac arrest or they can simply pass out and, die. So third degree heart block is what the name of the game is in terms of prevention and in terms of pacemakers. Because if you think about pacemakers now, it's like having an iMac in your chest. They can do everything. They're dual leads, dual chambers. They can sense, they can sequentially pace, they can inhibit, DDD. They can do everything. And there's two leads, and so they can do it. And so the bottom line is, the pathology is important in terms of driving how a pacemaker should be programmed. But they can do everything. So just as a schema here, PR segment. Now, if time is our x-axis, we're gonna think about three clinically important intervals of time on the EKG, and they are the PR segment, the QRS duration, and the QT duration. The PR segment, because we want to know how long it takes for the atrial depolarization wave to reach the AV node. The QRS segment, because we need to know that the left and the right ventricle are synchronously depolarizing at the same time, so we get coordinated output from the left ventricle. And the QT interval, the beginning of the Q, the end of the T wave, the QT interval, because we want to know that the time from the onset of depolarization to the onset of repolarization has provided an adequate interval of time so that we don't overlap with the next beat. And that overlap can have disastrous consequences and set up, arrhythmias like VTAC, VFib, and so on. So the clinically important intervals we're going to learn about with the I, the first I of intervals is PR, QRS, and QT. Okay, and let me just introduce this really super important concept if you didn't already know it, which is when we're looking at elevations, we all know classic ischemia is ST depression and T wave inversion. Classic injury is ST elevation. And classic infarct is Q wave formation. And I'm going to elaborate on all those in a little bit. But if you're talking about elevations and depressions, from where? From who? The PR segment is your isoelectric baseline for all measurements of your ST segment. So when you're dropping a horizontal to figure out how many millimeters of depression I got or how many millimeters of elevation, you go from PR segment to next PR segment, you draw horizontal. And the classic measurement of elevation depression is 2 boxes beyond the J point. So your QRS ends and 2 boxes beyond the very end of the QRS, that's where you drop your perpendicular and you measure height or depression, elevation or depression. We also characterize morphology of ST segments. Is it upsloping? Is it downsloping? Concave? I'm going to talk about that in a minute. But I just wanted to introduce this concept. This is for measuring, okay? And talk about sensitivity and specificity with regard to EKGs. The greater the drop, the greater the elevation, the more specific the finding, right? The more leads that are affected, the higher the elevations, the more likely the injury. The more leads that are affected, the deeper the drop, the more likely ischemia. Okay? But before we interpret EKGs, you got to look at it really quickly and say, is this a good EKG? And I'm going to tell you 2 quick ways to do that. This is a perfectly drawn, you could not draw a better EKG. And we're going to ask 2 questions. We're going to ask the question about the axial or the limb leads. For anyone who's done an EKG, it's pretty hard to make a mistake here because it says LA, RA, LL, RL, right? But sometimes I make a mistake. But if those leads are all connected correctly on the limbs, what should happen is that lead 1 and lead AVR should look like almost like mirror images. In other words, lead 1, if this is the heart in the middle of the room, lead 1 is over here looking at everything. And lead AVR is like in the corner of between the roof and looking down on everything. And wouldn't it make sense that things going that way are going to look like they're coming away from this lead? Things coming toward this lead are going to look like they're going away from that lead. So we have this mirror image thing. Now, it's not a perfect mirror image because it isn't wall to wall. It's ceiling to wall. But the idea is P wave is up, P wave is down. QRS is up, QRS is down. T wave is up, T wave is down. Done. Axial leads are connected correctly. Move on. Next question, we're going to look at the precordial leads. Now, these are subject to more error. Okay, and this is why your nurse typically should bring the EKG to you to look at before the patient is disconnected. Because there are, where those leads are placed can depend on the patient's chest, breast, chest morphology. And if they're too high, they're missing the heart. If they're too low, they're missing the heart. So the question here is going to be, is R wave progression normal across V1 through V6? Now, I should go back and say, your QRS is that ventricular depolarization. The first downward deflection below the baseline is Q. The next upward deflection is R. The next downward deflection is S. So it makes sense when I say R wave progression, we're looking at the peaks, 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 peaks. And what we should see is a QRS that is small, getting bigger, getting bigger, getting bigger, and now getting smaller and smaller. We should see R wave progression. Why? Because that's where the left ventricle is. And if height equals force, doesn't it make sense that the peaking of the R wave should occur out at V5 or V6 or V4 or V5 and then get smaller? So we want to see normal R wave progression. And these are our 2 validity questions, and you can see how quickly you can answer them. Now, in a pathologic heart, you may have all the leads connected correctly, but there still be pathological lead R waves. Remember, how much force does dead tissue generate? 0 force. So what if I have an anterior infarct and I have Q wave, Q wave, Q wave, and then R waves? Is it connected incorrectly? I have poor R wave progression. No, this is when you go into the room, you check the patient, you make sure the leads are connected, and now you say, I've got this is a valid EKG. I just need to interpret it because there's an abnormal finding. Does that make sense? Okay. All right. So that's kind of the backdrop for asking questions. And we're gonna run through a bunch of cases. Now, what I'm gonna do is go to the next slide. We're gonna ask the question. I'll go to the next slide where the case is magnified, and I'm going to ask you to go to your handout or go to your phone and just answer the question. So here, and we'll see how many of these we can get through because each of them have an important teaching point. This is an EKG from an otherwise healthy 15-year-old, and these are your possible rejoinders. And I'm going to show you your cardiogram there, and you can actually even look at it on your phone, and you're going to tell me what you think. Okay, and I like that answer. Sinus arrhythmia. So if normal sinus rhythm, what we just saw with our validity check, that perfectly drawn EKG was the standard. Notice how here, if we, now, remember when we read EKGs, we're looking at 3 leads simultaneously, and then the infinitesimal line, there's nothing that is that narrow and that high on other than a pacemaker spike, okay? There's nothing on an EKG, and what's happening is the leads are changing. So we're looking at 3 windows, and then all of a sudden, simultaneously, we're looking at 3 new windows, and then 3 more. So these 3-second segments are 3 different leads. And if ever you have a question about a given lead, say, oh, you know what? Is that the T wave? I'm going to look right below it. And oh, yeah, that is the T wave. Okay. You ever have, and you are going to have questions around QRS duration, ST elevation. Always use your leads above and below to corroborate what you think you're seeing. Time is our x-axis, and you'll notice there's no rhythm strip here, which is unfortunate, right? Most EKGs, this is an old EKG, most have 12 leads depicted, 1, 2, 3, RLF, 1, 2, V1, 2, 3, V4, V5 to 6, and then a rhythm strip down below. The rhythm strip is when we're doing our rate rhythm axis, we'd go to rate and rhythm on our rhythm strip. But you don't need a rhythm strip. Well, let's start with this. What lead, if you had to choose one lead that's going to tell you the most about atrial and ventricular depolarization of the 12 windows I've given you, what lead would you like to see? Yeah, lead 2. It's the perfect lead. Lead 2, down here on the floor, looking at everything's coming at me. Atrial depolarization, ventricular depolarization. It's the perfect lead. And so typically it's lead 2. Sometimes you'll see lead V1 or V2 as your rhythm strip, but typically it's lead 2. Here, the reason this is sinus arrhythmia is you're watching this go, and look at the R complexes, R wave, R wave. Well, now it's shorter, now it's narrow, that's the same, now it's wider again. You might say atrial fibrillation, but look at the P waves. Every one of these QRSs is preceded by a P wave. And the presence of P waves, discernible P waves, makes this a sinus arrhythmia. We also know in children, if you take the time to do the physical exam and actually monitor their heart, sinus arrhythmia is the rule in children. They have respiratory variation in their heart rate. You'll be listening. It's not sinus arrhythmia. It's the respiratory variation. Then we have normal variation that is sinus arrhythmia. Now, remember what I said about our algorithm? It's clinical context, validity, clinical context. You take this EKG, and this is not a 15-year-old. Let's call this a 75-year-old. Now we got a different animal. Sinus arrhythmia, 75-year-old, maybe that's the first sign of sick sinus. Maybe this is the first sign of impending pacemaker failure. Maybe this is going to be a problem. So clinical context plays all the role with EKG interpretation. And here, this is the rule in children. This would be abnormal, not necessarily pathologic, but abnormal in an older adult. Okay. All right. Next question. We got a 21-year-old with a history of seizure disorder, off medication. And this is what the EKG looks like. And I'm going to give you the case to look at. And then you go back to your phone and vote on what you think the right answer was. Okay, and you guys said, I'm waiting for someone to answer. Okay, I like that. That is the right answer. This would be in a 21-year-old, you would think about congenital prolonged QT versus drug effect causing a prolonged QT. Now let's talk about the QT. First of all, let's identify this EKG as a perfect example of a rhythm strip, lead 2. Nice lead depiction of lead change. Isn't this nice? It's color coordinated for us. Labels the leads, tells us everything. And when you got to you would go through this, rate, rhythm, axis, the 4 eyes, you get to the first eye, PR, QRS, and then QT prolongation. When you get to QT, what you're going to notice is if you were to measure the beginning of the QRS and the end of the T wave, and look at that interval, it exceeds half the R to R interval. And that's the easy down and dirty rule for QT prolongation that works for normal heart rates. If you have a heart rate that's out of the 60 to 100 range, you need to use a corrected QT. I'll give you a couple of factoids on QT interval. One is if it's more than 450, it's probably a problem, right? So 450 is sort of our cutoff, but it is related 450 milliseconds, but it is related to age, sex, medications, and it's also related to rate, because the QT should naturally be shorter for faster heart rates and naturally be longer for longer heart rates, right? For slower heart rates. And in this case, this QT, we're going to use the rule that it exceeds half the R to R interval. So this is a nice rule to remember for QT prolongation. For those patients on phenothiazines, on type 1A antiarrhythmics, on antidepressants, and you're measuring QT, if you can remember this rule, you got the ball game going. You could use corrected QT always, but this is a nice one to remember. Half of the RR interval. If it is prolonged, there's a jingle to remember. Drugs, lights, CNS, drugs, type 1 antiarrhythmics, all the psychiatry drugs, okay, TCAs, phenothiazines, even the atypicals, okay? Lights, all the hypos, hypokalemia. Remember, as potassium goes, so goes magnesium. So hypokalemia, hypomagnesemia, hypocalcemia. And then for some bizarre reason, CNS catastrophes cause QT prolongation. So, and then I taught you if the QT is prolonged more than 450, it typically is prolonged. So just a nice little rubric to remember with regard to QT. Okay. 66-year-old, long-standing history of hypertension. And I'm asking you, is it a bundle branch block? Is it ischemia? Is it right axis deviation? This is the cardiogram. Okay, I'm going to see what, okay. Any other answers? Okay, I'm going to show you how to know that this is a left bundle branch block. Cannot rule out lateral ischemia. Okay, this is a left bundle branch block with associated repolarization abnormality. Cannot rule out lateral ischemia. Okay, so where am I going with this? If we depict the heart here and we draw it in cross section and we block the right bundle, so these are the conduction tissue, and red depicts the depolarization, the red waveform turning into the blue, the two fascicles, the anterior fascicle, the posterior fascicle, the left bundle being much more potent, if you will, and more meaningful than the right bundle, which if the right, and this is the right ventricle, so the fascicle going to the right bundle is called the right bundle, if you will. Notice if you block a right bundle, it's one fascicle. If you block a left bundle proximally, like here, it's a bifascicular block. You're affecting two fascicles of wiring. More tissues affected. Except that, and let me just also point out that depending upon where the block is, you can have a very heterogeneous appearance to these disorders. Hence the rabbit ears, or the rabbit that doesn't look like a rabbit. Okay, as we're going to show in a second with right bundles. But hence if you block it proximally, really close to its origin, you're going to get classic features to your disorder. But the way I want you to remember this, and the sort of EKG for dummies way of remembering this, which helps me, is first identifying that the QRS is prolonged. If the QRS is prolonged, And the QRS is normal is less than 2.5 boxes. QRS is simply 3 boxes. That's 3 times 0.04. That's 0.12 seconds. If the QRS is just 20 milliseconds longer than it should be, you have 4 things in your differential: right bundle branch, left bundle branch, intraventricular conduction defect, or IBBB, incomplete bundle branch block, or pseudo bundle Wolff-Parkinson-White. Let me show you all those disorders in a second. Okay, so we go back to the EKG here. Everyone agree? You could stand in the back of the room and say that QRS is bizarre and wide. It's not narrow. It's not narrow. You got bundle branch, incomplete bundle, or Wolff-Parkinson-White. So that's our differential. Now, the answer to which bundle is blocked has to do with thinking about the late forces of the QRS and where do they peak. Do you notice the late force of the QRS peaks in lead 1, in lead AVL, in lead V5, and lead V6? In fact, you get this notching. And notice where it isn't. In V1 and V2, the late forces of the QRS are not up there. They're not toward those leads, they're away. That's where the left ventricle is out over here. If the late forces to the, because, let's go back to the picture. If I block the left bundle, I delay depolarization to the left ventricle. And what happens is via cell to cell, just like the atria, now instead of using conduction tissue, it's cell to cell transfer that eventually depolarizes the whole left ventricle. So the answer to which bundle branch block you're looking at is what are the late forces of the QRS doing? If they point to the left, you've blocked the left bundle. If they point to the right ventricle, and everyone knows the right ventricle is not really on the right, it's in front of the heart. It's where V1 and V2 are. This is why right bundles give us the peaking of the rabbit ear in V1 or V2. And this is why left bundles give us the peaking in 1, AVL, V5, and V6, because that's where the boot of the left ventricle is anyway, right? And if you depolarize abnormally, instead of using conduction tissue and the wiring, I cut the wire so that I hit the switch and all the lights don't go on. The lights eventually go on because of cell-to-cell transit. You know, if I do that, I repolarize abnormally. And here's where you get the deep S waves that everyone was looking at and saying, oh, that's ischemia. It could be. But what this really is left bundle branch block with associated repolarization abnormality cannot rule out lateral ischemia. In the case of a right bundle branch block, I get a peaking of R waves, late forces anteriorly, and negative forces laterally. 1, AVL, V5, V6, negative forces, not forces to AVL. The left ventricle has already gone out. The left ventricle is already depolarized. But that looks like the force here looks like force away from those leads. And so you can really differentiate the 2 bundle branch blocks simply by looking at where the forces peak. Now, the IBBB, or the IVCD, however you want to put it, incomplete intraventricular conduction defect, it's a morphology that neither matches the left or the right bundle. So if your prolonged QRS doesn't look like a left or a right, and it's slightly less than 3 boxes, that's where this IBBB comes in, okay? So you are right to identify this as possible lateral ischemia, because when we think about the left ventricle, we really have, for all intents and purposes, 3 walls of the ventricle. We have the lateral wall, we have the anterior wall, and we have the inferior wall. The lateral wall is best represented by leads 1, AVL, V5, and V6. The anterior wall of the ventricle is best represented by leads V1, V2, V3. And the inferior wall of the left ventricle is best represented by leads 2, 3, and AVF. Hence, we have the lateral, anterior, and inferior leads. So when we look for ischemia, when we look for injury, when we look for infarct, we look at lead distributions that make sense. And never does one single finding make a diagnosis. We want to see a constellation of findings that match those particular leads. And the reason why this is of greater consequence than this, so your patient comes in and has a left bundle, you're sending them to the cardiologist. Your patient comes in and has a right bundle, you may be sending them to the cardiologist, but maybe not. Because the right bundle is just of less consequence. The right bundle, everything still happens okay here, and you've still got a lot of conduction tissue to work with. When you block your left bundle, this is more of a concern. You've already blocked 2 fascicles. So a bifascicular block is always worse than a unifascicular block. Okay. Any questions on that? Does that make sense? Question? You know, I don't want to say no, because if you depolarize abnormally, you repolarize abnormally. So if there's enough, and remember, there's a lot of heterogeneity. Where's the defect? Is it may not be clear, you know, and so here's the way the EKG goes. You always call the worst case scenario, and then everything else could be below that. So if you think it's ischemia, I would not fault you for saying this was lateral ischemia, but you also have to identify the patient has left bundle branch block with probable repolarization abnormality. And this is what, but the truth be told, patients come in with this disorder and they have chest pain, and you know what we do with EKG? You throw it away, because now you need to evaluate them in the context of everything else. Their troponins, you know, their enzymes, there's other studies, because this, you can't reliably see ischemia on an EKG that already shows what looks like ischemia. Okay. And what you also can't do with this patient is put them on a treadmill, right? Because you put them on a treadmill, they've already got an abnormality. What are they going to get? More of an abnormality? So that isn't a positive test. The person who goes on the treadmill is a person who can walk, who can exercise, could do whether you're going to do an arm ergometer, you're going to exercise them, but they have a baseline normal EKG. Okay. And the reason we don't do a lot of them is because people don't have baseline normal EKGs, and that's why we go to nuclear stress tests. All right. And everyone, you know, and also the cardiologists don't want to waste the time with a $200 test. No, I don't want to say that, and do a $1,000 test. But the reality is, cardiology needs to be present for a treadmill test, and it takes time. And they're not nearly as sensitive. Here we go. Not nearly as sensitive. And if your pretest probability is high, you need a more specific test. You're not going to say someone who's got hyperlipidemia, chest pain, hypertension, male, greater than 65, smoker, has a normal stress test, normal EKG. There just isn't enough sensitivity in the tests to make it a valid test. So you end up going to a more specific test when your pretest probability is high. Question? Yeah. Probably not. But the question is always why? And when you have conduction disorder problems, there are three common causes of conduction. So think about the wiring in the heart. Think about where it goes in the interventricular septum, and tell me the top three causes where the wiring can become faulty. Ischemia. So you kill tissue. Ischemia goes to injury, goes to infarction. You have dead tissue, you're going to ruin the wiring. That's number one. So that's where people say, okay, I'm going to rule out ischemic heart disease. What's number two? Hint, it's the thing between the chambers. So valvular heart disease. So if the valves are defective or in some way regurgitant or stenotic, but valvular heart disease, because remember, as the valves do funky things, they get stenotic, and that stenosis and calcium gets its way to right to the conducting. The interventricular septum is where the trigonal valves sit. Three of the valves are right there. So you get calcium deposited in your interventricular septum, you're going to have a conduction problem, potentially. And the third is the old rule of aging, which is just doesn't work as well as it used to. You know, idiopathic degenerative sclerosis of the pathways. And so people age and their pathways just don't work as well. So it's that differential that needs to be put in clinical context. So you're right, you wouldn't acutely do something unless they had chest pain and it's a new change in their EKG. Okay, good. All right, you got a 30-year-old with a 5-year history of well-controlled hypertension. I ask you if this is LAD, early repol, left bundle, or non-specific STT wave changes, and this is the EKG. Let's see how everyone will weighed in here. Okay, LAD. So early repolarization abnormality, for those who have taken the family medicine recertification exam, it's uncanny how early repol shows up. I've taken the exam, I don't know, 5 times in my life or something. It's shown up at least 3 times. So this is one worth learning, if not for that, for the fact that it's a common abnormality that we see in young, healthy people. Early repolarization abnormality. What do we say is the repol? It's the T wave. Look at these T waves. First of all, the QT looks rather short. But do you notice how in leads V2, V3, V4, if you were looking at this and you were at the third eye of ischemia, injury, and an infarction, I wouldn't fault you for saying, you know what, there looks like there's elevation in leads V2, V3, and V5. If I use your rule of checking the PR segment to PR segment to PR segment, there is elevation. I'm in the wrong set of leads. There is elevation here. Again, where's the J point? Well, the J point is where the QRS ends, and there's a slope here. You're going to have to look at a clearly depicted QRS and say, okay, it's this wide, therefore it's this wide, therefore my J point somewhere around here. I'm going to measure 2 boxes beyond the J point, and I'm going to use the PR segment. You can see there's 3 millimeters of elevation, 3 millimeters of elevation, 2 millimeters of elevation. What is classical ST elevation more than 2 millimeters in the V2, V3, V4, or V1, V2 distribution? That's anterior myocardial injury until proven otherwise. No, that's not what this is. Because it's more than just how high it goes. It's also, what is the ST segment doing? Okay, and I'm going to introduce the concept here that if you take a slope between the J point and your peaking of your T wave, and if your waveform is underneath it, we're going to call that concave. If your waveform is over it, we're going to call it convex. And it's the morphology of the waveform, the height of the elevation, the clinical presentation, and the age of this patient that makes this EKG early repol. You give me a 75-year-old with hyperlipidemia, hypertension, previous history of coronary artery disease, presenting with chest pain, I'm not calling this early repol. I don't care what the morphology of that looks like. This is ST elevation until proven otherwise. So clinical context changed the interpretation here. But I'd like you to just know and identify this in a young person. This is early repolarization abnormality. Common, I see so many of these people get alarmed in the office and, you know, calm down, patient's okay. Just early repol. Okay. All right. I'm going to go to a better one than that one. Let's see. And a better one than this is a good EK. This is a tough one. Okay. 60-year-old with thrombophilia due to lupus, anticoagulant syndrome, and she presents with chest pain. This is what the EKG looks like. This is not an easy one. Okay, let's see how you guys weighed in. Whoops, wrong direction. Okay. And that is the correct answer. Acute inferior MI with second-degree heart block. Let's look at why. So if we got to the third eye, so we went intervals and enlargements, which we haven't really talked about yet, 4 chambers. The third eye, the triad, ischemia, injury, infarction. If we got to the third eye, you recognize that in leads 2, 3, and AVF, Q waves are starting to form. And there's ST elevation that blends right into the T wave. You might say, how do I know that? Well, look at the lead above where I can clearly see the T wave. Drop your line down. You can see that's your T wave, and you can see your ST segment is elevated. Elevation. Now, it's not 6 millimeters, but it's 3 millimeters of elevation. And it's elevated enough in two or more contiguous leads, 2, 3, AVF, Q waves forming. This is exactly what happens with an MI in evolution. You injure the tissue. You can reversibly deprive tissue of oxygen with ischemia. But once you start to injure the tissue, you injure it from endocardium to epicardium. Endocardium injury causes a non-Q wave MI. Your elevation of your enzymes, but no manifestation of Q waves on your EKG. It's still an MI nonetheless, and it's like a subendocardial is to MI what TIA is to stroke. It's a warning, right? You keep injuring that tissue, you go from endocardial, just burning rubber, to all the way through transmural injury. Now you form Q waves, and I'll explain why in a minute. But that's what's happening here. This is injury turning it into infarct while we're watching it. And then if you look at your rhythm strip, you were astute enough to notice something funky is going on here. Patient has a beat here. Then their P wave is a little, PR interval is a little longer. Now it's yet longer. This is the P wave preceding it. And then all of a sudden, the P wave occurs and you drop a beat. This is the progressive PR prolongation of second degree heart block and Wenckebach phenomena. And you might say, well, why are they having an arrhythmia at the same time they're having an inferior MI? And this is almost exactly when it occurs. Inferior wall of the left ventricle sits right next to the conduction tissue in a right coronary dominant system. And this is exactly what happens. You see these weird Wenckebachs and degree heart blocks, this transient abnormalities in inferior MIs. That said, you'd rather have an inferior than an anterior. You'd rather have an inferior than a lateral wall MI. These are so much more energetic, if you will, in terms of getting the blood flow out. You can wall off a left inferior end mark and do well for a long time. You lose 20 to 30% of your anterior wall, you are a cardiac cripple. You are HFrEF with 15% ejection fraction. So the name of the game in all this, right, for us is early identification and early intervention. And what is it, door to cath lab time for PCI, right? Get the patient from the ED, from your office, into the cath lab where they can get a PCI, percutaneous coronary intervention, whether that means angioplasty, whether that means stent, whether it means surgical standby because they can't do any of those things, right? But that's the cardiology standard of care currently. So this is a good case. I think they're all good cases, but I'm biased. I'm going to try, for the sake of time, move us through some of the more interesting ones. I think I'm going the wrong direction here. Okay, there we go. Okay. Just to reiterate the point about where the blockade occurs with Wenckebach, it's a progressive block that occurs, and as the block gets more and more refractory, the PR prolongs, and all of a sudden it drops a beat. That's your Mobitz type 1 phenomena. Remember, Mobitz type 1 and first degree heart block sit on one side of needing a pacemaker. The erratic Mobitz type 2, non-predictable dropping of erratic beats, and third degree heart block, mandatory pacemaker. We all know that from our ACLS. Okay. All right. Okay. I just want to point out with right bundle, I'm just trying to do this for the sake of time. But the right bundle, remember, if the right bundle branch is blocked, the last thing to depolarize is the right ventricle. If the right ventricle is represented by forces in V1 and V2, it makes sense that you're going to have a RS-R prime, or a rabbit ear. Just remember, there's a lot of mutant bunnies running around out there with one big ear and one little ear. Okay, because of where you block the right bundle. If you block it really proximally, you're going to get a classic appearance. But if you block it distally, you're going to get a mutant. Okay. I'm going to walk through these. We have 10 minutes, so I'm just going to walk through some findings and just highlight them for you. kind of a quick pictorial. Okay. Everyone loves to see hyperkalemia on EKGs. You almost never see it. It's specific, but not sensitive. But when the QRS peaks, when the repolarization mark peaks well above the QRS, you better be thinking serious hyperkalemia. These are the kind that go into, cardiac arrhythmias. Okay. So you'll see patients with CKD, and their potassium's 5.6, 6.1. The EKG doesn't show anything. But when it's 6.8, it's going to show something. And that's the case here. We didn't talk about left ventricular hypertrophy. So let's talk a little bit about that. That's like the most, if there was one important chamber enlargement to know the diagnostic criteria for, it's left ventricular hypertrophy. Now, why is that the case? Because the left ventricular hypertrophy is to hypertension what proliferative diabetic retinopathy and chronic kidney disease is to diabetes. It is an endpoint of disease organ manifestation. When that left ventricle hypertrophies, it's not like it's getting strong, like hypertrophying, like a muscle getting, no, it's outgrowing its blood supply. And that muscle is at risk. It's at jeopardy for an infarction. So LVH is a disease endpoint for hypertension. And so why do we follow the sprint trials? Why do we follow the ACH criteria for treating hypertension? Because we're trying to prevent, the end stage diseases that are associated with hypertension. And we now know lower is better, provided a patient can tolerate medications from sprint. But the idea that if you have LVH, you already almost lost the game. Now you've got to put a patient on such potent drugs to try to regress their LVH because they are at risk. LVH is myocardium at risk. So it behooves us to be able to identify on an EKG, because we are doing EKGs in patients with hypertension. Do they or do they not have LVH? Okay, so I made that point. Now here's the rub. There's no perfect criteria for LVH. Like there are 30 different criteria for LVH. And if you're an internist, they used to teach the Estes criteria, where you were measuring point system and adding up points. And the more points you had, the more LVH you had. Well, and then there's a Cornell criteria, the Scheidt criteria. Here's the deal. If you can remember 35 and strain in patients age greater than 35, that's 95% specific for LVH. Meaning, if you have it, you got LVH. Okay, what's the 35? 35 is the S wave in 1 added to the taller of the R wave in V5 or V6. Now, why do we do anything? I mean, this makes sense. Big leads out here. Oh my gosh, maybe the ventricle's really hypertrophied. But doesn't it make sense? V1, why would I have an S wave? V1 R wave points this way. S wave and V1 points behind me. You can see how the S and the V1 is meaningful in suggesting that the left ventricle has concentrically hypertrophied. And if you can remember 35 and you measure from the baseline, this is minus 20. This is positive, 30 already. Greater than 35 in patient age greater than 35. That 35 criteria only applies to adults age greater than 35. Children, you have to use age matched criteria. The other thing that makes this LVH is what you guys might recognize as lateral ischemia. ST depression, a little bit of coving out of the waveforms, just not quite normal. Okay, not really classic for ischemia, but that's strain. Strain, I like to think of if the ventricle is gotten so hypertrophied, the repolarization is going to change. It's a repolarization variant associated with this hypertrophy. And the specificity of this is 95%. That's really, 95% specificity for anything is a really high number. So if you can remember, now there are other criteria, and you can look at the R wave in AVL greater than 12. You can look at the R in 1 added to the S in 3 greater than 25. You can look at left axis, left atrial abnormality or left axis deviation. Those are additional criteria. But if you can remember 35 and strain patient age greater than 35, you've done something, and that's good. Okay. And here, this slide actually depicts in one fell swoop, depicts all the LVH criteria you could possibly want to imagine. Tall R wave in V1, not this, like this. Tall R wave in V1. Deep S wave in lead three, not the R wave toward lead three, the S component that's up over here. Notice how when you start to do this, now you're talking about left axis deviation, right? And that's when you have left ventricular hypertrophy, your natural axis is going to be leftward or left axis deviation. I'll talk about that in a second. Notice the deep S wave, the tall R wave, the greater of the two, greater than 35. Notice the left atrial abnormality, that's the biphasic P wave in lead V1. Notice the LAD. Okay, now what is LAD? Left axis deviation. Axis is like the most confused but simplest thing ever on the EKG. Axis says, first of all, axis has nothing to do with the precordial leads. Has nothing to do with V1 through V6. Axis simply says, in these 6 leads, where, if I were to take the summation vector of all the electrical activity, where would it point? Doesn't it make sense that usually the axis is right in the direction of lead 2? But if the axis sum ends up over here, why would, and now, now it's up over lead 1, AVL. If it's up over at minus 30, it would make no, why would the sum of electrical activity end up over here? 2 major reasons. 1, you got ventricular hypertrophy. And 2, you got dead tissue down here. So dead tissue generates no force, and all of a sudden you get this up over here. But I was going to say, here's the simplest rule for axis. I know you guys meant 1 is 1 up, is F down. I had the tip to tail. No. Here's the easiest. You want the easiest rule? Here it is. Where's the biggest QRS? The biggest QRS in the axial leads always approximates the ventricular sum. It has to. You can't have a huge QRS in lead 2 and the axis not be in that direction. So if you're going to approximate 6 leads, why not simply approximate it by 1 lead? Where is the tallest QRS? And if we did that with this lead, we'd say, okay, lead 1. Yep, lead 1. So lead 1, that's going to put me in left. Now, there are 4 quadrants for axis. Okay, so let's make the quadrant. There's this, anything in here is normal. Anything in here is abnormal. We say from here to minus 30 leftward, minus 30 more left axis deviation. Okay, so this is all pathologic moving in this direction. Over here, this is all right axis deviation. Why would the ventricular sum ever shift over to the right? Well, I can tell you, there's a lot of reasons. PE, COPD, valvular heart disease, when you get right ventricular hypertrophy. Okay, why would the axis ever be up here? It would never be up here unless you've got some very peculiar, bizarre EKG or dextrocardia or some other. The axis is never in this brain. So always the question is it more left than 0, i.e. leftward, or is it left axis deviation, or is it more left, more right than 90 degrees, which puts it in right axis deviation? And here you would have to say it's positive in 1, it's isoelectric in AVF. That is, it's as tall as it is positive as it is negative. That means you take a vector sum, R equals S, vector sum is 0. If vector sum is 0 on AVF, that means there's no net force in the direction of AVF. This is exactly at 0 degrees. That's the axis. And where's the biggest QRS? Just like I told you, it's in lead 1, where the biggest QRS is. That's where your axis is. So you don't have to do tip to tail method. You can approximate axis just simply looking for the largest QRS. Okay, I hope that's a helpful teaching point. Okay. And then here I'm just pointing out the strain that is associated with when you have mega voltage depolarizations, you have mega repolarization abnormality, and that strain, for all intensive purposes, could be lateral ischemia. So you know your correct interpretation when you have LVH with strain is typically LVH with strain cannot rule out lateral ischemia. Now you have serial EKGs that all look the same. The patient doesn't have an ischemia in front of your eyes now. It's just that's what they have. They have LVH with strain. You want to corroborate LVH, you get an echo. You have a question about your EKG, you get an echo. Because you're going to treat, I don't care what a patient's blood pressure is, if they have LVH, you're going to treat them more aggressively. Multimodal therapy, lots of drugs. Get that LVH down. I mean, that's you're trying to target that endpoint so that they don't have ischemic heart disease. I am gonna, and let's just, I'll just show you what I just talked about with axis. This photograph, this slide from Netter is showing if the right ventricle is hypertrophied, notice how the net force points to the right. If the left ventricle is hypertrophied, notice how the net force points to the left. And in the normal heart, when you add all the collectively the electrical depolarizations together, it's typically in the normal range. And of course, this would occur with lung problems, pulmonary hypertension, COPD. This would occur with untreated or poorly treated hypertension, aortic stenosis, death of tissue. Okay. I want to show you guys one more EKG, and so if you will bear with me. This EKG, this is why you don't moonlight when you're a resident. I was a resident at UCLA, moonlighting as a second year, and this young lady came into the urgent care that I was working in, having just relapsed from her cocaine addiction. And she was having chest pain and having difficulty breathing. This EKG, and this is a real, look at this EKG, and it's just, you know, this is a EKG that for the ages. Massive ST elevations in the anterior leads, V1, V2, V3, V4, Q wave forming in V1, V2, V3, okay? This is called tombstone T waves. You could write an epitaph underneath there. This patient is, her tissue is dying as we speak. Not because she's got coronary artery disease, but because she has such severe vasospastic disease, right? And it's cut off her blood supply. She needs nitroglycerin. She needs a unit. She needs more than I can give her in urgent care, that's for sure. And, you know, she went immediately to the hospital. But what a tragic case of injury, unnecessary injury in a young person, okay? So I do want to point out one thing that probably would be of value to you, and then we're going to look at the last case. And that is the formation of a Q wave. You know, we scratch our head and we go, you just said dead tissue, no force. Why shouldn't it just be zero? Right? No, if you kill tissue, from endocardium to epicardium, you kill the tissue. It's like if I was a mirror looking over this, it's like I'm looking through glass. I see no force because the dead tissue generates no force. But why the Q wave? Well, look carefully. I'm over here looking through. I don't see anything here, but on the other side of the heart, I see a depolarization from endocardium to epicardium. That force is always away from me. Hence the Q wave. The Q wave is not force generated by dead tissue. It's the contralateral wall that always has a depolarization vector from endocardium to epicardium. It may be minute. That's why the Q wave sometimes it leaves little tiny blips, and sometimes they're huge. Just depends. But that's the genesis of a Q wave. It's not that you're generating force. It's like you're looking through, and you want to see they have to be wide enough and deep enough and in the right distribution to make a diagnosis. So 2 or more, 1 millimeter wide, at least 1/3 to 1/4 in depth, the height of the R complex for them to be meaningful. And that's the diagnosis of infarction. And infarction tissue, unfortunately, doesn't come back. It's dead tissue. And the whole name of the game here is to try to prevent it. So in that context, let me take you to my patient who sorry, I have to go through the 100 slides to get there. But my last patient this lovely lady, and by the way, all these cases are worth looking at. They're good cases. They're illustrative, a lot of good teaching points. I try to bring in a couple of cases from the hospital setting. And then there's a nice algorithm of the concept of the 4 A's of arrhythmia. So if you put supraventricular tachycardias in one category, what drug would you use that starts with an A to treat it? If you had bradycardia and asystole, what drugs that starts with an A? If you have asystole, VFib, or pulseless electric activity, what drug with an A? And you have VTAC, VFib, and I'm going to fill in the blanks for you. Adenosine, atropine, adrenaline, which is epinephrine. Okay, a little play on words there. And then amiodarone. So it's a nice way to remember just across, because these drugs, there's a lot of them to remember, but the A drugs help us through this algorithm. And then finally, my patient here, and I have a nice picture of her there, and that's after her procedure. So she presented, she had diabetes, hypertension, obesity. She's seen for atypical chest pain, and she's noting that just at the peak of exertion, she has the pain. So she's short of breath. She gets short of breath right when she's really at the end of her activity. And if she relaxes, it goes away. Okay. So this sounds like, in this patient, ischemic heart disease until proven otherwise. Everyone would agree, right? So she has a baseline abnormal EKG, and this is it. And you say, well, what's abnormal about it? Well, she's got kind of diffuse non-specific STT wave changes. And her symptoms are so specific for angina that I'm not going to go to a sensitive test. I'm going to go to a very specific test. So I send her for as you guys would, a DEXI. In our hospital, it's a cardiolite, Lexi scan, DEXI scan. It's a nuclear agent that's used to perfuse the heart after a pharmacologic agent is given to preferentially dilate the coronary arteries, right? So we use cardiolite and thallium, we use adenosine and regadenosin, but they're basically called nuclear studies, right? A nuclear study. And a nuclear study does this. It's like mimicking exercise. So you have blockages. So mimicking exercise, you give the agent and you infuse the dye, and before the agent is given, you infuse the dye and you look at the perfusion around the heart. Then you give the agent, which preferentially dilates the coronary arteries, and you look at the dye and you look to see, is there a match? Is there an area of deficit that then reperfuses over time, right? And it's this mismatching that really drives the next test, which would be a cath and an intervention. My patient has a normal nuclear scan. There's no differential uptake. There's no areas of hypoperfusion that then reperfuse. She has a normal scan. Okay. I send her to GI, pulmonary. I keep evaluating because it's a specific test. It's a DEXI scan. It's a nuclear stress test, right? It's like got 90+% specificity. The GI doc says to me, he sends it back and he goes, I'd have cardiology look at her again. I call the cardiologist. I said, you know what? Would you would you consider cathing her? And we talked about it. She gets cath. She has a widowmaker lesion. Widowmaker, that's the left main, affecting all the circulation. And why the negative stress test? Because all of her vessels were so uniformly diseased that the perfusion worked, and then it didn't work. It looked uniform. There was because the test depends on one blockage, not uniform blockages. And she ended up getting revascularized. It's done very, very well. But what an interesting case. And by the way, she has triple vessel disease, and this is her EKG. So put all this in perspective. You can learn everything you need to know about EKGs. I call it a 70% test. It's about 70% of the time helpful, and 30% of the time it does you no good, because it does not help you. The only thing here that would throw me, it would say, it's non-specific, it's abnormal, it's not, but you know what? Her symptoms drive where she went with her treatment. And so I want to leave you with the idea that, learn the skills. You learn by covering up the interpretation and looking at it first, interpreting it, then exposing the interpretation and going, oh yeah, I see why that is. Or maybe asking the question like, oh, why is that? Because I didn't see it, and that's the way you build your skills with EKGs. But it is not, I don't consider it a very complicated task to do. Yes, there are some bizarre variants, but boy, when you get normal down, when you have variations from normal. And it's that which would prompt probable referral from our arena as primary care folks. Okay. Thank you all very much. This is your wonderful, wonderful audience. It is 1:17. I went a little bit over, but you got a few minutes extra. And I just really appreciate your attention, your questions, and thanks for providing me in advance, for providing feedback, whether this was helpful to you or whether it could be what could be more helpful for your specific work. Okay. Thank you.